All right, let's talk about the EEG. If you've ever gotten one of these reports back and just felt a little overwhelmed, you're definitely not alone. So in this explainer, we're going to demystify this thing. We're going to look at why it's such a critical tool for seizures and epilepsy, but also, and maybe more importantly, why it has some serious limitations you've got to understand.
Okay, picture this. You're in the clinic, and you're faced with one of the most common and life-changing questions in neurology. Your patient just had their first seizure. Now, is this a one-time thing, or is it epilepsy? Considering that almost 1 in 10 people will have a seizure in their lifetime, but way less than half of them actually have epilepsy, well, the stakes are pretty high. Getting it right is absolutely crucial, and that's where the EEG steps into the picture.
And this really gets to the heart of the challenge. On one hand, the EEG is amazing. It can help confirm that a weird spell was in fact a seizure, it supports the diagnosis of epilepsy, and it can even help you pinpoint the exact syndrome. But, and this is a big but, it is not a perfect test. The little electrical signatures we're hunting for can be super infrequent and easy to miss. And to make it even trickier, some perfectly healthy people can have an EEG that looks abnormal. It's this balancing act that we really have to master.
So before we can even begin to talk about reading an EEG, we've got to understand where the squiggly lines come from in the first place. So let's do a quick peek under the hood at how we actually record the brain's electrical symphony.
The whole process is actually pretty standard. First, a technician places electrodes all over the scalp using this universal map called the 10-20 system. That just ensures that an EEG in one hospital can be compared to an EEG in another. Then, we hit record. And finally, we often try what are called activation procedures, things like having the patient breathe really fast or look at a strobe light. We're basically trying to gently provoke the brain to see if we can coax out any abnormalities that might be hiding. Now, you'll hear this term montages thrown around. The camera angle analogy is honestly perfect. Think about it. There's no single best way to look at the brain's activity. Montages are just different ways of connecting the electrode inputs to give us different views, different perspectives. A good EEG reader will flip through a bunch of these montages to get a full 3D picture of what's happening and make sure they're not getting fooled by an artifact.
Okay, so the recording is done. Now we get to the most important part. What are we actually looking for in all those pages of squiggly lines? Let's dive into the key signs of epilepsy we're trying to hunt down.
This is the money term, right here. Interictal epileptiform discharge, or IED. Interictal just means between seizures. So think of IEDs as the electrical footprints that epilepsy leaves behind. They're these little telltale blips that act as biomarkers for a brain that's prone to seizures. When you order an EEG for a suspected seizure, this is the main thing you're hoping to find.
You'll often see reports mention two main types of IEDs, spikes and sharp waves. The only real difference is how long they last on the screen. Spikes are super fast, less than 70 milliseconds, while sharp waves are a little bit longer. But here is the absolute key takeaway. Diagnostically, they mean the exact same thing. One is not scarier or more significant than the other. So how do we know a pointy-looking wave is a real IED and not just, some muscle artifact or a random blip? Well, there are actually formal criteria for this, published by the International Federation of Clinical Neurophysiology. It's kind of like a checklist. To be called a true IED, a wave needs to meet at least 4 of these criteria. It has to have a certain shape, stand out from the background, and create an electrical field that makes biological sense. It's how we separate the real signal from all the noise. Now, besides those single IEDs, there's another really important pattern you'll see, especially in sick, hospitalized patients. They're called LPDs, and they're these rhythmic, repetitive discharges happening over one side of the brain. When you see this on an EEG report, your antenna for seizures should go way, way up. The vast majority of patients with LPDs are having seizures. We've seen what we're looking for, but how often do we actually find it? And what does it mean when we do? Or maybe more importantly, when we don't? This gets us to the real-world clinical challenge of using the EEG. If there is one number, one statistic you take away from this whole explainer, please let it be this one. For a patient who definitely has epilepsy, the chance you'll find an IED on their very first routine 30-minute EEG is only between 20 and 55%. Just let that sink in for a second. It is shockingly low. This means a normal first EEG in someone with epilepsy isn't just possible, it's common. So what's the solution to that low number? Simple. We repeat the test.
This chart shows you exactly why that's so critical. With just one EEG, we're at, say, 40%, but look what happens. With the second EEG, our chances jump up to around 65%. By the time we get to a fourth one, we're up in the 85% range. So the lesson is, if your clinical suspicion is high, don't give up after one normal test.
So the test has low sensitivity. But what about the flip side? Specificity. Well, it's actually highly specific, but, and you knew there was a but coming, it's not perfect. A really big study found that about 1.74% of people with zero history of seizures will still have IEDs on their EEG. It's a small number, but it's a critical reminder that finding an IED does not automatically equal a diagnosis of epilepsy if the patient's story doesn't fit.
This brings us to what might just be the most practical, need-to-know part of this entire discussion: how to avoid the common mistakes and misinterpretations that can lead to a misdiagnosis. Because the EEG is just full of patterns that can look scary, but are actually totally harmless.
Let's start with the absolute golden rule. I want you to burn this quote into your brain. Because the sensitivity is so low on any single test, a normal EEG absolutely, positively never rules out epilepsy. The diagnosis is clinical, it's based on the story. The EEG is just a supportive data point. And here they are, the usual suspects. This table is your guide to the most common EEG mimics that can trip up even experienced clinicians. Take wicked spikes. They're sharp, rhythmic, and show up in the temporal lobes. I mean, they look for all the world like something bad, but they're completely normal. Same thing for BETS, which stands for benign epileptiform transients of sleep. Knowing about these mimics is what prevents us from overreading a report and putting a patient on medications they don't need. And really, it all just boils down to this single crucial point. The EEG provides data. It gives us clues. It offers supporting evidence. But it is not a verdict. The diagnosis of epilepsy is made by you, the clinician, by carefully listening to your patient's story and putting all the pieces of the puzzle together. The EEG is there to support your judgment, never to replace it.
And so, I'll leave you with this question to think about. When that next EEG report lands on your desk, whether it's normal, abnormal, or somewhere in between, you're the one who has to weigh all the evidence. How are you going to combine that patient's story with the data from their brainwaves to make the right call? That, right there, is the art and the challenge of medicine.